We now move to postmenopausal pelvic mass. Postmenopausal pelvic mass, the first thing you should think of is ovarian cancer. So you could have a pelvic mass which is from the GI tract as well. But since today we are all gynecologists, we need to think, could it be ovarian cancer? And here's our case. A 70-year-old woman, 70, comes for annual exam with lower abdominal discomfort. Now remember we talked about that women who have normal pap smears only need to have a pap smear every 3 years. That doesn't mean that they don't need an annual exam for other reasons. And this woman, even though she's 70, comes in for an annual exam, which she should. What symptoms does she have? Lower abdominal discomfort. Kind of vague symptoms. No weight loss or abdominal distension, but she has lower abdominal discomfort. Wisely, you do a pelvic exam, and what do you find? You find a non-tender, 6 centimeter, solid, irregular, fixed left adnexal mass. Does this have the hallmarks of being benign or malignant? Would you rather have a non-tender or a tender mass? I'd rather have a tender one. It's more likely to be inflammatory. A large or a small one? A small one. A solid or a cystic one? Cystic. Irregular or smooth? I'd rather have a smooth one. Fixed or mobile? See, these are not good signs. Solid, irregular, fixed, non-tender. 70-year-old woman complaining of GI symptoms, you must think ovarian cancer. All right, this is where we're going to go. We're going to look at, there are 3 organ systems in the pelvis. There's the GI tract, there's a urinary tract, there's a reproductive tract. We're not going to go into detail the GI tract and the urinary tract, but always think of that. Could you have colon cancer? Could you have diverticulosis, diverticulitis? Could you have a ureterocele? Could you have a pelvic kidney? Our interest, of course, is in the reproductive tract. Our preoperative workup, we're going to get tumor markers, and we'll talk about these in some detail as we go along. The most common ovarian cancer is epithelial, 80%. The tumor markers are CEA and CA125. The second most common, but you can see it's way down from 80, it's only 15%, is germ cell tumors. And that is tumor markers LDH, which is seen with dysgerminoma, beta HCG, which is seen with choriocarcinoma, and alpha-fetoprotein, which is seen with your endodermal sinus tumor. The least common ovarian cancer is gonadal-stromal. These can be hormonally active. The granulosa cells produce estrogen. A Sertoli Leydig cell tumor produces testosterone. Epithelial are seen with what age group women? Mostly with the older women. Germ cell tumors are seen most commonly with what age women? Younger women. And your gonadal-stromal can be seen with any age group, whether it is pubertal, prepubertal, whether it is reproductive years, or whether it is postmenopausal. We always want to get a chest x-ray, because if there's distant metastasis, it may be to the lung. T and X means type and cross-match, because she's going to need a lot of blood potentially. We will do our staging laparotomy. The most common stage we find ovarian cancer is stage 3. Mean survival, 18 months at stage 3. We'll get peritoneal washings, we'll get biopsies wherever we find tumor masses, take out as much as we can, a total abdominal hysterectomy, bilateral salpingo-oophorectomy, take out the omentum, and to cytoreductive debulking, take the tumor down as much as possible. Leave no larger masses than 1 to 1.5 centimeters. Prevention, we'll talk about this by decreasing lifetime ovulations and early detection pelvic exam and BRCA1 gene. These are women who are at particularly high risk. These are ultrasounds of a postmenopausal woman. In 1998, the ovary measured 2.7 centimeters. In 1999, it measured 4.3 centimeters. What should happen to the size of the ovary postmenopausally? Get bigger? No. should get smaller. In fact, it should be so small and atrophic that you cannot palpate it. I don't like this. It's getting big. Look at the hypervascularity that you see on the power Doppler and notice excrescences, septations. This is not a good sign. This looks at the relative place of ovarian cancer in terms of number of deaths and number of cases. And you can see in number of deaths, ovarian cancer is 1, 2, 3, 4, 5. And in terms of cases, number of cases, it is also 1, 2, 3, 4, 5. So 4 to 5% of cancers in women are going to be ovarian cancer. 1% of women will die from ovarian cancer. Here you can see causes of death in women: lung, thank you, Virginia Slims. No question. Smoking. Breast, colorectal, pancreas, ovaries down here. The most common gynecologic cancer is endometrium. Ovary is number 2, second. Cervix, and then vulva. The age group, we've already gone over these. The most common age for cervix is a younger woman in her 40s. We see some women in their 30s. All the rest are in their 60s. And notice ovarian cancer is toward the end of the 60s. This looks at the cancer mortality rates in the United States, with blue being the lowest and red being the highest. Now this is interesting because when you look generally at health conditions in the United States, the South has higher rates of all kinds of diseases, particularly infectious diseases. But here we see it is predominantly in the West and in the North with ovarian cancer. Okay, definition. Pelvic mass after menopause. And as I already mentioned, you should not be able to palpate the ovaries postmenopausally. They should be small and they should be atrophic. We talked about GI tract. We talked about urinary tract. And if you're uncertain, CT scan, ultrasound, barium enema may be helpful. In terms of urinary tract, intravenous pyelogram can be helpful. But in all of these cases, you're going to have to explore the patient. This is a surgical diagnosis. What do we use for a screening test? Now, when we have cancer of the cervix, we do a pap smear, right? So that's our screening test. Occult blood in the stool for colorectal cancer. Patients who have postmenopausal endometrial cancer will have bleeding. There is no early finding with ovarian cancer. And how good is a pelvic exam? It depends so much on the operator, on your experience, on the patient's abdominal wall, how well relaxed is she, and yet we're kind of stuck with a pelvic exam. How about ultrasound? Now you think, my goodness, ultrasound should be able to see if there is a pelvic mass, and in fact it does. This was a study done out of Cedars-Sinai Hospital in Los Angeles at the Gilder Radner Tumor Center. And what they looked at was postmenopausal women who had routine ultrasounds of the pelvis. And on those women who had a mass, they were operated on. Out of 100 women who were operated on for a postmenopausal pelvic mass, what percentage were ovarian cancer? Out of 100, 3. 3. Can you justify operating on 97 women unnecessarily to find 3 cases with ovarian cancer? And the answer is no. Unfortunately, ovarian cancer can spread even without ovarian enlargement in the first early stages. Now, there's all kinds of research screening tests, and you don't need to know this. This is just to give you a feel for where we're going. There's a lot of blood tests which are being used to try to identify, is there a difference in women who have ovarian cancer and those who don't? There's matrix metalloproteinases, there's lysophosphatidic acid, there's various growth factors. None of them at this point are to the place for clinical usefulness, but we desperately need something like that. So what we've got really is a pelvic exam. How good is ovarian cancer in terms of detection using ultrasound. And this is looking at the cost to detect one survivor from these various kinds of cancer. So what we look at is the prevalence, how common is the cancer, what does it cost to screen, and how much money would you need to spend to pick up one survivor. Cervical cancer using pap smears, $17,000. That's not bad. Prostate cancer with PSA, prostate-specific antigen screening, $20,000. Even breast using mammograms, $41,000 to pick up one survivor. But look at the ovary. And the reason it costs so much is because we have such a high rate of false positives, so you've got to put in the cost of all of these unnecessary surgeries. So, ultrasound, no. We do not use this for screening for asymptomatic women for ovarian cancer. All right, we've looked at some of this data already. Epidemiologically, the mean age is in the late 60s, 69 years of age. 1% of women will die of ovarian cancer. It is the most common gynecologic cancer which leads to death. Endometrial is the most common, which is diagnosed, but because it's usually diagnosed in stage 1, mortality rate is low. Let's look at risk factors. BRCA1 gene, positive family history. Now these are clearly linked together, and women who have positive BRCA1 gene also have an increased risk of what other cancer? Breast cancer. The BRCA1 gene is a repairing gene. When there is a problem, the BRCA gene will repair the area which is affected. Now, when we look at risk factors, the number of lifetime ovulations appears to be a risk. The more likely a woman has had many, many ovulations, and it appears that on the ovarian capsule, the area of the ovulation breaks through the capsule, and there is a defect in the reparative mechanism because of the BRCA1 gene. And that is then where we have an increased risk of ovarian cancer. We're coming back to that in just a minute when we look at protective factors. What protects is decreased lifetime ovulations. Now, a woman who's been on oral contraceptive pills, which suppresses FSH and LH, you don't have the LH surge, is going to have decreased lifetime ovulations. And we will see in just a few minutes, there is a 50% decrease in ovarian epithelial cancer with oral contraceptive pills. Women who have chronic anovulations, such as PCOS, have less ovulations, have less ovarian epithelial cancer. Now, this is an interesting one. Women who have a tubal ligation have decreased ovarian cancer. Now, how can you hypothesize that? Well, what we do know is that women who dust their perineum with talc powder after bathing have a higher rate of ovarian cancer. Now, the only hypothesis you can bring is that the talc powder gets into the vagina, goes up through the cervix, through the uterus, through the tube, deposits on the ovary, and we know that talc can irritate and cause adhesions and ovarian cancer. By ligating the tube, you prevent the egress or ingress of these various substances. At least that's my best guess on that. Women who breastfeed have fewer ovulations, and obviously if you have a short reproductive life, either late puberty, early menopause, you're going to have less ovulations as well. Now let's look at the BRCA1 gene. These women have a 50% chance of ovarian cancer. So what are you going to do? You're going to take out their ovaries early? How early? What would be a reasonable approach on these women? And no one really knows, although the studies would suggest that oral contraceptive pills can actually decrease ovarian cancer in these women. But clearly, once they have finished childbearing, remove the ovaries. Now, this is a significant point, is that even if you take out the ovaries, they can still develop peritoneal mucinous carcinomatosis, which is a malignant degeneration of the serosa of the abdominal cavity, of the peritoneal lining. And here's what it looks like. And so you take out the ovaries and you think, well, there's no chance of her getting any cancer. Well, that's not true. So you always need to be vigilant, even in these cases. And you can see this diffuse cancer. This is a histogram that shows ovarian cancer rates by age and breast cancer rates by age. And you can see the shape of the curve is almost identical. And what this says, age is a significant factor for ovarian and breast cancer. Young women, very low. As they get older, it gets higher. And the peak age you can see is between 60 and 70. The peak age here is between 55 and 70. But notice the relative numbers. This is 47 per 100,000 ovarian cancer. Breast cancer is 240. So it is 4 to 5 times higher rate of breast cancer than ovarian cancer. Ovarian cancer at age 40, 1 in 2,500. Age 50, 1 in 1,500. And you can see as we get older, the risk goes up. We've done a pretty good job in decreasing the mortality of cervical cancer. How about ovarian cancer? Pretty lousy. It really hasn't changed much at all. And the reason is because we have no early identification. The symptoms prior to diagnoses. This was a survey of 1,725 women with ovarian cancer. 3 months before diagnosis, most of the patients had GI symptoms. Who did they go see? The primary care practitioner, the general internist. What did the doctor say? My doctor said, Mylanta. So they get GI cocktails, antacids. I would make a plea to you because 50% of you all are going to become primary care physicians. If a postmenopausal woman comes in with GI complaints, has she had a recent pelvic exam? Ovarian cancer whispers. Whispers. It doesn't scream at you, so you really got to listen. Endometrial cancer screams at you, bleeding. Cervical cancer screams at you. Pap smear is abnormal. Ovarian cancer, not a whole lot. So you've got to really listen carefully. GI symptoms, think, could she have ovarian cancer? This is an article looking at ovarian cancer. And what were the symptoms of ovarian carcinoma? And what did they find? Unusual bloating, abdominal fullness, pressure, pain. Those are the prominent symptoms in women with ovarian cancer. It's not specific. They're very non-specific. All right, how does it spread? Cervical cancer spreads into the pelvis. It can go down to the vagina. Endometrial cancer spreads into the myometrium. Those are the immediate adjacent tissues. What are the tissues that are adjacent to the ovaries? The ovaries are hanging on the mesovarium. There is no immediately adjacent tissues. The malignant cells will drop off, and where do they go? They go down into the peritoneal fluid. And the peritoneal fluid will carry it all over, and watch this. It goes from the pelvis, and it goes everywhere. It goes into the lateral gutters where the bowel is. It goes behind the liver and the diaphragm. It goes behind the spleen. It is intraperitoneal spread. And this is important when you look at therapy. If you have endometrial cancer, you can radiate the pelvis. If you have cervical cancer, you can radiate the pelvis. Can you radiate all this area here? You're going to kill the patient. You can't give abdominal radiation. The bowel, the kidneys, the liver can't handle it. So you're basically stuck with surgery and chemotherapy. So spreads all over, intraperitoneal spread of ovarian carcinoma. Okay, this is looking at the relationship between oral contraceptive use and ovarian carcinoma. Again, relative risk of 1. If it is above 1, we have increased the risk. If it's below, we have reduced the risk. And you can see where the mean is. Almost all these studies, with one exception, the risk is reduced. And I would put my line probably around 50%. So there's a 50% reduction of both endometrial cancer and ovarian cancer with oral contraceptive pills. And the reason is you have decreased lifetime ovulations. Now in your notes is this figure that looks at all the different kinds of ovarian cancer. You can see epithelial cancer, which is the most common, germ cell, and then gonadal stromal or sex cord tumors. I don't know of any organ in the body that has this many different kinds of cancer. The ovary is certainly unique in that respect. Okay, let's summarize what we said about the ovarian cancer. The most common is epithelial, 80%. The age group is going to be the older women. Germ cell tumors are about 15% of the total, and this age group is going to be younger. The gonadal stromal or sex cord tumors is the least common, 5%, and this is found in all age groups, both the younger and the older. All right, and that's what we've summarized right here. The histology, the most common epithelial is serous, mucinous endometrioid. The tumor markers, CA125. We'll talk about that in just a minute. CEA. Tumor markers are blood tests that you can look for, which, if elevated with a cancer, will decline and decrease as the cancer is destroyed. If you have recurrence of the tumor markers will come back. These are not used for screening. Germ cell tumors, younger women, dysgerminoma, endodermal sinus tumor, teratoma, choriocarcinoma, and dysgerminoma, the tumor marker is LDH, endodermal sinus tumor is alpha-fetoprotein, and choriocarcinoma is HCG. The gonadal stromal, and there's a whole bunch of those, you saw that on the list. The ones I think you should remember for the board exam is granulosa cell and Sertoli Leydig cell tumor. The granulosa cell produces estrogen. If you have a postmenopausal woman who has a granulosa cell tumor, what symptoms will she have? She'll probably have endometrial hyperplasia and probably bleeding. You have a postmenopausal woman with Sertoli Leydig cell tumor producing testosterone, you will probably see virilization. Metastatic tumors, they can come from elsewhere to the ovary, and typically they will be bilateral. Where do they come from? They can come from the endometrium by spreading through the uterine cavity, through the tube, and then onto the ovary. That is going to be stage 3 endometrial cancer. They can be from the GI tract. They can come from the breast. My mother, some years ago, was diagnosed with ascites. Ultrasound shows bilateral ovarian tumors, large ovaries. Exploratory laparotomy, did a histology on them. The ovaries were normal. There was nothing wrong with the ovaries, but it was metastatic from someplace else. That was a papillary adenocarcinoma. Now, where did it come from? They did a DNC, endometrium was normal. Did a mammogram, breast was normal. Did an upper and lower GI, they were both normal. Did a ultrasound of the pancreas, that was normal. Thyroid scan, that was normal. Never did find out where the primary was. If you have an older woman who has bilateral cancer, think metastasis. Now here's one for the boards. Krukenberg tumor. This is ovarian cancer metastatic from the GI tract, often from the stomach. How's that for trivia? Krukenberg tumor. Anyway, if you've got room in your hard disk, stick it there, someplace. Okay, if you look at websites for ovarian cancer detection, you will find many websites of women who say the following: my doctor insisted that I get a CA-125 test to see if I had ovarian cancer. And the test was positive, and they found ovarian cancer, but they found it early. They were able to get it out in time, and I am cancer-free. Every woman should insist that their doctor get a CA-125 level on them. Just like with men, you get a PSA test. What do you think of that? Screening using CA-125. A good screening test has high sensitivity, which means if it is negative, you know you don't have it. Ideally, it has high specificity, which means it excludes the normals. But you need to have high specificity. Unfortunately, CA-125 can be negative in 50% of women with early ovarian cancer, and even in later stage cancer, is 25% can be negative. And look at these benign causes of CA-125. Leiomyomas can cause an elevation of CA-125. Adenomyosis, endometriosis. PID, pregnancy, even menses can cause elevation of CA-125, and there's no tumor there. So a positive doesn't mean that you've got ovarian cancer. A negative doesn't mean you don't have it. CA-125 is not used for screening for ovarian cancer. Staging, we've already talked about staging. And in ovarian cancer, as with endometrial cancer, it is a surgical staging. Which of the 4 stages is the most common with ovarian cancer? And it is stage 3. Stage 1, limited to the ovaries. Stage 2, extension to the pelvis. Stage 3, peritoneal spread or positive nodes. And stage 4 is distant metastasis. The most common is stage 3. Should you know all of these subgroups? Probably not. But I would like to spend some time on stage 1 because stage 1 has some unique management differences. Stage 1A is involving one ovary only, the capsule is intact, and cytology is negative. In other words, peritoneal washings, no malignant cells. Now you'd think if it was involving only one ovary, if the capsule was intact, if there is no malignant cells in the peritoneum, wouldn't you expect 100% survival if you take out that ovary alone? Unfortunately, that's not the case, because you can have a negative cytology and miss cancer cells which may be in the peritoneum. So it's not 100%. The recommendations still are, if you have a postmenopausal woman, even if it's stage 1A, would do a TAH-BSO, and we'll come back to that in just a minute. But let's say she is a young woman, and she has stage 1A, which is just really an incidental finding in most cases. Then it may be reasonable to do a unilateral subpingual oophorectomy, advise her to have her childbearing as soon as possible, and then to have a TAH-BSO. So in a sense, this would be similar to the prepubertal girl who has unilateral localized to one ovary to do a unilateral BSO and otherwise leave it intact. 1B is both ovaries involved, but the capsule is intact. The implication is that it hasn't spread. Cytology is negative. 1C, the difference here is there is one or both ovaries which are involved, but the cytology is positive, which means that there is positive peritoneal washings. There is microscopic spread into the peritoneal cavity, even though there are no gross lesions. In this case, what you can do is to instill into the peritoneal cavity radioactive phosphorus, P32. The radioactive phosphorus will radiate, but only to maybe a millimeter. And that's really all you need to destroy microscopic spread in the peritoneal cavity. So stage 1A would be unique in that sense that if it's premenopausal and she hasn't completed childbearing, do a unilateral subpingual oophorectomy, and then advise childbearing and then do a TAH-BSO when that is done. With 1C, we would use In addition to the THBSO, we would do a intraperitoneal radioactive phosphorus. Now, this isn't the radiation which will destroy the liver and the kidneys and the bowel. This is only very minimal thickness. Okay, I already alluded to this before. What stage is ovarian cancer usually diagnosed? It is in stage 3. You can see the majority is in stage 3. And what is the survival, 5-year survival at stage 3? 15%. Stage 1, you think it would be 100%, but it's not 100% because you can miss that microscopic metastasis that is not found in the peritoneal washings. And this shows in yellow the percentage diagnosed at each stage, and you can see the majority is stage 3. The survival is in the blue bars, and clearly that is related to the stage. The earlier the stage, the better the survival. Okay, this is a kind of a busy slide, got lots of lines on it, but it looks at what is the 5-year survival on the x-axis. The percentage is survival over time, and we're looking at various degrees of stage. The most common is stage 3, and that is the brown curve. Notice 50% survival, less than 18 months. Half of the patients would be dead 18 months from diagnosis. Now, here's stage 1A. Survival is just less than 90%, even with 1A, and that's because you did not pick up the microscopic metastasis, even though you did the peritoneal washings. So, even 1A, THBSO. And here you can see as a 5-year survival at stage 3 is between 15 and 20%. And that hasn't changed a whole lot, unfortunately. Look at this gross picture here. This shows very tragically the intraperitoneal spread. This, I believe, is probably an autopsy specimen. But you can see the diffuse spread intraperitoneal of the carcinoma. All right, postmenopausal adnexal mass, basic management, surgical exploration. You've got to go in there and find out what's going on. If it is benign, then that's going to make a difference. And you can have benign cysts of the ovary, even though she's postmenopausal. If it's benign, you could just say stop the surgery there and not do anything further. Most surgeons would say now that we're in here, and since 1% of women will die of ovarian cancer, let's do a THBSO anyway. But if it's malignant, we've got to do the surgical staging. We talked about that. The THBSO omentectomy. Why do we take out the omentum? Because the omentum is a policeman of the abdomen. The policeman of the abdomen says, come unto me, whatever the problem. Tumor, foreign body, infection, the omentum will surround it. And you have these omental cakes. Omentum just caked with tumor. Take it out. Debulking, take out as much of the tumor as possible. We call this cytoreductive debulking surgery. It used to be in the olden days. General surgeon would open up grandma, find cancer all over, say, well, we can't take it out, just close her up, send her home to die. Nowadays, we know that that is not the best way. The debulking surgery is better. And then chemotherapy. Notice, no radiation, because you're going to kill the patient otherwise. If you do optimal debulking, cut out as much of the tumor mass, reduce the tumor load, mean survival 52 months. If you don't do good debulking, you can see it is only half. So you can extend the mean survival, even though it's not going to be a cure. But some patients will get a cure. This is a patient that I diagnosed with stage 3 ovarian cancer, 10-year survival. She saw her children grow up, her daughter got married, has grandchildren. This woman is 3 years from stage 3 ovarian cancer. And you recognize Coretta Scott King, Dr. King's wife. She died of ovarian cancer. She had a stroke. She had a lot of other things that happened as well. But cancer is no respecter of persons. If there are unilocular ovarian cysts, simple cysts, in a postmenopausal woman, this can be managed conservatively, and they are rarely malignant. Anytime you have a simple cyst, it is usually pretty benign. Okay, next is adnexal mass with ascites, which is really a more severe ovarian cancer, which has spread a lot further. A 65-year-old woman is referred for evaluation of ascites, adnexal mass, has noted abdominal distension for 6 months. Again, it is the abdominal complaints. On pelvic exam, we have the usual, a large, irregular, solid mass, not mobile. That is more consistent with a cancer than a benign etiology. Anytime you have ascites, you've got to think of, could there be heart disease, you've got kidney disease, liver disease, you've got low albumin. But in our situation today as gynecologists, we must think, could there be ovarian cancer? We talked about the workup, abdominal pelvic CT, looking at what the source may be. Could it be GI? Could it be reproductive tract? But in any event, you're going to have to operate. Surgical staging, peritoneal washings, we talked about that. Examine the entire peritoneal cavity. Multiple biopsies. It may take 30, 40 biopsies. Then the debulking surgery. Try to reduce the tumor mass as much as possible. TAH, BSO, omentectomy. Remove as much of the tumor as possible. And then you're basically left with chemotherapy. Radiation is not an option because of the hazards to the bowel, to the liver. How's your brain? Do you have any room left in your brain? If you do, carboplatinum and Taxol are the usual chemotherapies used for ovarian cancer. And if there are tumor markers which are positive, those can be helpful because then if you see a rise in the tumor markers, it could suggest that you have a recurrence of the tumor. But they're not used for screening. All right. So, postmenopausal pelvic mass, make sure it isn't from the GI, the urinary tract, get your tumor markers, staging laparotomy, peritoneal washings, biopsies, TAH, BSO, omentectomy, debulking, and chemotherapy. And that's the end of postmenopausal pelvic mass.